I want to welcome everybody to this week's session of Dermpath Happy Hour. As is always the case, if you have any questions during the presentation, please feel free to post them in the chat. I'll be minding that. Alternatively, if you think about a question later, or if you're watching the recorded video, please feel free to send any questions to education@sagisdx.com, or you can email me directly, tdavis@sagisdx.com. This evening, we're very happy and excited to have Dr. Gabriel Oaxaca hosting the session. Dr. Oaxaca attended medical school at Baylor University after doing his undergraduate work at Rice University. Subsequently did AP and CP residency training, as well as dermatopathology fellowship training at the Cleveland Clinic before joining us at Sagis Diagnostics. And Dr. Oaxaca will be discussing 6 tumors that you don't want to miss. This is a very high yield session for any of you preparing for the Dermpath core of the applied exam. So without any further hesitation, I'll turn the floor over to Dr. Oaxaca. Gabriel?
Well, thank you so much, Dr. Davis, for that introduction. So today we're going to go over several diagnoses that you don't want to miss. There's definitely, for those who previewed the slides, an emphasis on soft tissue lesions today. And because of that, we're going to want to kind of establish some common language just to make sure everyone's on the same page. And so I'm going to share a quick PowerPoint that I made. All right, so we're going to be talking about spindled and epithelioid cells. Okay, so on our left, we have a spindled cell. Basically, they're elongated, and as opposed to an epithelioid cell, which is kind of recapitulating more like an epithelial cell, like cuboidal, squamous, columnar, something to that effect, and looks more like epithelial lining, but in fact is not. So other important things to just kind of keep in your mind in terms of descriptions, you could see that this particular nucleus is completely blacked out, very dense, if you will. So this would be hyperchromatic. And then over here, our nucleus is kind of more like a bag with a bunch of little chromatin dots in it. So this would be more so a vesicular chromatin, a vesicular meaning like a bag. And then in this particular case, we can also see a very prominent nucleolus. So this would be a macronucleolus, and in this case, it's cherry red, which is kind of a buzzword for melanoma, should you ever hear that particular descriptor. And then additionally, a lot of these cases, it's not really possible, or I should say, you can't say with 100% certainty what the diagnosis is without a little bit of ancillary immunohistochemical staining. And here we'll review how to establish a lineage of differentiation, which helps narrow down our potential differential and hone in on the final diagnosis. So anything epithelial, as in like carcinomas, that should stain with cytokeratins. There are many different cocktails that are used. AE1, AE3 is a big workhorse. And then if you're wondering, say, about a poorly differentiated squamous cell carcinoma, it may lose certain components of the keratins it once expressed. So you might be more successful in getting like a high weight molecular keratin, which are typically expressed in tougher epithelium, such as seen in the skin, as opposed to an adenocarcinoma, which would typically express lower molecular weight cytokeratins. Then we have, of course, melanocytic. Always important to rule out melanocytic lesions whenever we're dealing with something that looks very high grade and not very well differentiated. So S100 and SOX10 are great for that. And then if you can also get something slightly more melanocyte specific, such as HMV45 and MART1, also known as melan A, then you basically have cinched your diagnosis. Other lines of differentiation include vascular. CD31, 34, and are good stains for vascular. I put a little star on CD34 just because CD34 can stain a lot of other things, not necessarily just endothelial cells, such as, like, say, blasts in like leukemia cutis or a DFSP. So it's just really important, and I want to emphasize the fact that CD34, you got to know what you want to be staining for prior to using it. Otherwise, you might get a result that you don't really know what to do with. For neural, you have S100 and SOX10. So obviously, there's a little bit of overlap between the melanocytic and neural, except that neural should really not, or never, stain for HMB45, MART1 melanae, the melanocytic differentiation markers. And then for smooth muscle, we have smooth muscle actin, very commonly referred to just as SMA, and desmin. Also of note, SMA can be a somewhat, it's very sensitive, but not necessarily specific. So we will encounter in today's cases some alternate uses of SMA other than just smooth muscle in the classic sense of, say, like a leiomyoma. Then we also have skeletal muscle, myogenin, myod1, say if one is considering a rhabdomyosarcoma. And then hematopoietic, this is definitely an oversimplification. However, CD45 is a decent immunohistochemical stain just to kind of narrow something down into potentially hematopoietic origin. There are some exceptions to CD45 staining in terms of hematopoietic, but we're not going to get into that at all in this lecture. And then within, like, carcinomas, there might be, like, certain lines of differentiation even within carcinomas themselves, such as neuroendocrine. And so we have synaptophysin, chromogranin, CD56, and INSM1 for that. Synaptophysin and chromogranin together being a really big workhorse. More recently, INSM1 has come out, and for a lot of neuroendocrine tumors, this is equally as sensitive and specific as just synaptophysin and chromogranin, though there are a lot of studies coming out, and depending on your tumor, it might be a little bit not as good as synaptochromo or a little bit better or equal to, so it's very dependent on the exact tumor that you're looking for. In terms of in Dermpath, this would be very readily applicable to Merkel cell carcinoma, in which INSM1 has been shown to be approximately the same as synaptophysin and chromogranin together. All right, and with that very brief primer, let's get into our cases. All right, so this is our first case. I don't believe clinical histories were provided for these, so that makes them all the more challenging. However, I'll provide just as we're going through what would be a classic presentation for most of these. All right, so this first case, the most common clinical presentation would be head and neck, elder individual, most likely male. And so with that, let's dive in. At low power, we have a very busy dermis, an infiltrate extending from the superficial papillary down to the deep. So the first impression is, like, this is probably something malignant. There are very few things that would be quite so diffuse and infiltrative. All right, so at higher power, let's take a look at the cells themselves. Based on our prior descriptions of what spindled and epithelioid mean, these would certainly fall more so under the epithelioid camp. We have even some vesicular nuclei with some pretty prominent nucleoli, even macronucleoli. If we scan around for a little bit, we'll also see some apoptotic debris. And although I'm not picking them up at this very moment, as I'm scrolling through, there are definitely several mitotic figures. Okay, so we've established that we think that whatever this is malignant. And so from there, we need to look at secondary characteristics of this lesion. So what I mean by that is there's only so much information you can get from the cells themselves. Then you got to see how they're organized and what else they're doing, maybe looking at the vessels, etc. All right, so here we have some what may seem like artifacts, but is actually part of the tumor. These slit-like vascular or slit-like spaces. I don't want to give it away too quickly. And they're lined by these same very pleomorphic epithelioid cells. So at this point, the slit-like spaces should be a very big indication that we're likely dealing with a vascular tumor. And based on our quick review of immunohistochemical staining, we would want to throw on some vascular markers such as CD31, CD34, or ERG. It's typically a good idea to use at least 2 to kind of cover up for the weaknesses of sensitivity and specificity of another stain. I typically gravitate towards CD31 and ERG just because they're cleaner stains, a little more specific to endothelium, and ERG itself is nuclear, which makes it really easy to read. All right. And if we're working this case up from what I like to call the very top, like brand new fresh case, I would also put on a cytokeratin and a melanocytic marker because that would enter into the differential, especially on the head and neck of an elderly individual. Lo and behold, this tumor is strongly and diffusely positive for CD31 and ERG. And at this point, the only malignant, overtly malignant, vascular tumor is an angiosarcoma. And given the morphology, it is actually an epithelioid angiosarcoma. And so some quick tidbits on angiosarcoma. They are most common on sun-exposed skin in elderly individuals. And this is, there are 2 different ways in pathways, if you will, for angiosarcoma. One is radiation/lymphedema, and then this one is sun damage associated. So for the lymphedema and chronic radiation associated angiosarcoma, those are interesting in that there's an additional immunohistochemical stain that one can perform and cinch the diagnosis with, and that is c-MYC. I do believe that is a pretty important thing to remember. So radiation and lymphedema associated angiosarcoma stains with c-MYC, and they have c-MYC amplification on molecular analysis. So yeah, epithelioid angiosarcoma. Our next case, let's start again at low power. This particular lesion would be seen in someone who's around 20 to 30 years old in distal extremities, commonly hands and fingers. So at low power, we have a nodular dermal-based proliferation, maybe even multinodular, if you consider this to be its own little nodule. And we see variation in the coloration of the lesion. Here it's more purple, here it's more white, here it's purple again. So let's find out what's going on within each of these zones. If we hone in on the central portion of the lesion, we have a whole heck of a lot of karyorectic debris and no actual cells that we can observe, at least any viable cells. So this is a large zone of geographic necrosis. And so as we move outside of the geographic necrosis into viable cells, we have kind of this plump spindle proliferation of variably sized spindle cells. They have irregular nuclear contours. Some are a little bit hyperchromatic. And so there is somewhat a degree of pleomorphism to this population. As we move even further out, these cells become more plump and epithelioid, definitely a lot more rounder. And there's a lot of admixed acute inflammation. And so if we were to scan around, probably find some mitoses in this lesion too. However, given the clinical scenario and the appearance of this lesion, the first thing to rule out should be an epithelioid sarcoma. The differential includes rheumatoid nodule, if this is interpreted as necrobiosis, or GA, should it be something more myxoid. However, these cells are quite atypical, and we have kind of varied morphology in them. So as you guys likely very much so know, rheumatoid nodules and granuloma annulare are composed of histiocytes, which these do not really look like. There are instances in which an epithelioid sarcoma may be very low grade and not very epithelioid to speak of, and mostly spindled, in which case the differential really does become quite challenging. At that point, immunohistochemical staining is very much so warranted. And in fact, in this case, it should also be performed just to verify the diagnosis. Interestingly, despite this being a sarcoma and not a carcinoma, it does, for the majority of the time, stain quite strongly with keratins. An AE1, AE3 will stain the majority of them. High molecular weight keratins, as is typical of a squamous cell carcinoma, should most of the time be negative in this. Actually, these would stain with low molecular weight keratins, such as CK818 or CAM5.2. They may co-express CD34, which is a very unique immunohistochemical profile, keratin plus CD34. And the one stain that, or another stain that should really be remembered for this particular lesion is loss of INI1. INI1 is essentially constitutively expressed in normal human tissue, and this sarcoma loses expression of INI1. At that point, with the clinical scenario and loss of that immunohistochemical stain, that is very much so diagnostic of epithelioid sarcoma. And something else of note, there are two variants of the epithelioid sarcoma, the proximal type and the distal type. The distal type, which is the one that we're viewing right now, is the one that is seen most commonly in a younger population, like 20s, 30s, and even children. The proximal type will most likely not be encountered in a routine dermatology practice, as those are much deeper lesions, typically seen in proximal extremities and limb girdles, below the fascia, just deep-seated lesions. And those are usually just very overtly malignant. But just to be aware that there are two variants of epithelioid sarcoma, proximal and distal, and they do have different age distributions. All right, next case. This one, let's say, is from a middle-aged individual, and it's from the thigh. So technically this lesion could arise essentially anywhere except for the abdominal wall. All right, so low power, we have a somewhat circumscribed, but also a little bit infiltrative proliferation. And something that's important to note, especially when dealing with soft tissue lesions, is to not immediately categorize something as quote unquote invasive. There are soft tissue lesions that are infiltrative, but still benign. So that's why that word infiltrative is kind of used as like a, hey, that looks like it's a little bit worrisome, but hey, it's not actually invasive. So it's kind of a good descriptive word to use, especially when you're unsure if something is overtly malignant or potentially benign. All right. And then other clues to this diagnosis can be noted at still low power. And here we have kind of more pink fibrous zones, and here we have more kind of blue tinged, almost myxoidy areas. And although it seems like it could potentially be artifact, there are also some areas where the tissue itself is almost kind of falling apart. And so this is referred to as cystic degeneration. All right, so moving in even closer to our cells, we see that they're kind of set in this fibrotic background, a very hard pink stroma. And the cells themselves, although they're somewhat variable in appearance, they're kind of like within the same spectrum. They're not pleomorphic. They might be a little bit enlarged, plump, spindled, some of them running in short fascicles, fascicles being bundles of the cells kind of streaming together, as we can see kind of right here. And then some of them kind of have a pulled apart appearance. I'm trying to find a particularly good example of one, but this is what's described as tissue culture-like appearance, kind of this stringiness to it, where you could kind of see the cytoplasmic processes of the cell kind of being pulled in either which way. It's most easily appreciated whenever you have one that's being pulled in 3 directions, and it's almost like well, it is described as a stellate fibroblast, because it looks a little bit like a star. We also might encounter some mitotic activity in this lesion. And although mitotic activity is typically an indicator of malignancy, in some lesions, it might just be an indicator of rapid growth, as would be in this one. Additional features that are important in making this diagnosis include extravasated erythrocytes. Not many tumors actually have that unless they're vascular in origin. That's a big reason why something might have extravasated erythrocytes. But if we were to run some vascular stains on this lesion, they would be negative and only highlight, the background vessels that we actually see. All right, so without further ado, this is nodular fasciitis. They typically have a history of very rapid growth, more so than you would expect from an actual malignancy, in the order of a couple weeks. And they may also spontaneously resolve. As quickly as they come, they may go away just as quickly. And for that reason, and the fact that a lot of them, or up to 50% in some studies, have a discernible history of prior trauma, it was unsure as to whether these represented a reactive process or an actual tumor. However, molecular studies have demonstrated a recurrent USP6 rearrangement in these tumors. And so now they are commonly thought of as actual tumors. If there was concern for other entities, the one immunohistochemical stain that might be helpful, as most of these are typically diagnosed on H&E, is an SMA. And the testing of these with immunohistochemical stains is usually in cases that are much more cellular, and the secondary features, which I pointed out, aren't as readily apparent. And so what an SMA is going to stain is not the fact that it's a smooth muscle tumor, because it's not. This is a fibroblastic myofibroblastic proliferation, are the contractile units within like the myofibroblast. So instead of having a diffuse staining pattern, as you would see in something that is truly a smooth muscle neoplasm, you would see the SMA staining in kind of following the cytoplasmic processes, sometimes kind of outlining the cell itself, but not fully staining the entirety of the cytoplasm. And that's what's known as quote unquote tram track staining. So that can be useful, but it shouldn't necessarily be a crutch or a 100% reason to not call something if it doesn't stain with SMA, because some cases just are devoid of SMA. And so then it becomes an H&E only diagnosis. They should be negative for, or they are, these lesions are negative for keratins, melanocytic, vascular, et cetera, et cetera, et cetera. The only thing is maybe some SMA. Items on the differential diagnosis might include desmoid fibromatosis, and that can be differentiated on histologic grounds, at least by the presence of long sweeping fascicles. As we noted in this particular case, our fascicles were pretty short. A long sweeping fascicle is a fascicle that goes at high power from one edge of the screen to the other edge of the screen. So you would just be seeing a very long stream of cells following one single direction. And If there was any further doubt, then there could be some immunohistochemical support with a beta-catenin for desmoid fibromatosis, and that would be a nuclear stain for beta-catenin in desmoid fibromatosis. Some rare instances, one might consider a low-grade fibromyxoid sarcoma, and the stain that would help differentiate for that would be a MUC4. All right, I think that's good for nodular fasciitis. All right, so our next case, as I'm sure many of you realized, does not actually fall into the sarcoma category. However, the morphology itself could be considered kind of small round blue, even though these cells are not that small. And so at low power, let's just start from the top again. We have an ulcerated shaved biopsy specimen and a proliferation of these deeply basophilic cells with some central necrosis. There are no cellular features to this. It is just cellular schmutz. All right. And in some areas, these basophilic cells are more so arranged in cords, somewhat infiltrative, in a variably hemorrhagic and myxoid stroma. So the important thing is to always be thinking about this diagnosis because it's on the differential or a much more common diagnosis of basal cell carcinoma. But this is much too disorganized, and we don't really have any palisading, and there is no retraction artifact. So those are some low power clues to start thinking about this diagnosis. Additionally, the nuclear features are very helpful in that notice how there is no pattern to the chromatin in these nuclei. There's also a very high nuclear to cytoplasmic ratio, and some of these nuclei are kind of impinging upon each other, also known as molding. And so what I just described are features of neuroendocrine tumors. And if we're dealing with a neuroendocrine tumor on a differential with a basal cell carcinoma, then we must think about Merkel cell carcinoma, which is what this one ended up being. A very boards relevant tidbit is that the CK20 is perinuclear dot-like in its appearance. And perinuclear dot-like, I'm not aware of that being used as a descriptor for pretty much anything else in dermatopathology. So it's basically the point where if someone says the words perinuclear dot-like to me, I'm like, oh, you're thinking Merkel. Like it's just a one-to-one association, and you're talking about a CK20. So that would be the case here. Additionally, we would have some of our neuroendocrine markers be positive here. So synaptophysin, chromogranin, INSM1. Excellent markers to get us to this diagnosis. And once we are here, we only have one more thing to worry about, which is, could this be a metastatic small cell carcinoma? And the most common place that would be from the lung. So another important marker would be a TTF1, which when negative lets us know that it is in fact not a metastasis. Of course, there are small exceptions to what I'm saying, but then like 95% plus of the cases, this is how it works. All right, so this is a Merkel cell carcinoma. For our next case, this is going to be another lesion that typically occurs on, or it definitely occurs on sun-exposed skin of typically more elder individuals. And at first glance, there might not seem like there's too much going on. Some low power clues to the diagnosis, or the biggest low power clue, are the presence of all these lymphoid aggregates. This is not seen in pretty much any normal variant of skin. And so this definitely warrants some higher power inspection. And so if we look at the epidermis, we find exactly what we're looking for, which is a component of melanoma in situ. And so now that we have melanoma in situ, and we have all these massive lymphoid aggregates, we're like, wait, well, where's the melanoma? And the answer is the melanoma is everywhere. All of this is desmoplastic melanoma. And let me show you the cytology to kind of hopefully convince you that it is in fact here. So note our spindle cells and note how variable they are in size. And they're also variably hyperchromatic. This is a desmoplastic melanoma is on the differential diagnosis with just scar, which is why our eyes might just gloss over it. But it's always important to keep a high index of suspicion on sun-exposed sites when you have lymphoid aggregates, and especially when you got your melanoma in situ up top. If I were to stain this with a SOX10 and S100, it would just be blazingly positive. However, a very important note to remember about desmoplastic melanoma is that almost by definition, it will lose its melanocyte-specific markers. So it will be negative for HMB45 and MART1. And so because of this, and there are some other instances where melanoma, and like particularly in cases where it's very poorly differentiated, may lose their melanocyte-specific markers, SOX10 and S100 are typically the best markers for getting something in the melanocytic camp. And then you might ask, well, isn't that the same as neural? And the answer is yes, it is. But in this clinical context and with the MIS overlying the lesion, there is no way that this could possibly be a neurofibroma or some other neural tumor. This is desmoplastic melanoma. And some important notes about it, we note that it is huge and it is very deep. So it would have technically a high pathologic T stage. And so high stage equals poor prognosis, except that not in this one. Interestingly, this lesion, although it may recur locally, it is incredibly rare for it to metastasize. So long as the criteria for a desmoplastic melanoma is used rigorously and accurately, you're basically guaranteeing, well, not guaranteeing, but getting pretty darn close to a guarantee that this lesion will behave much, much, much better than a superficial spreading or lentigo malignant melanoma of the same depth. All right. And so moving forward, this lesion will also happen on the sun-exposed skin of an elderly individual, most commonly head and neck. All right, so we're going to pull from a lot of what we learned in the other cases to get this one right. All right, so low power, we see an infiltrate arranged in sheets. I don't see any discernible features like nodules or, well, yeah, it's just a sheet of tumor cells. And then we go in at higher power, and we can see that this lesion is riddled with mitotic figures. And some of them are even atypical mitotic figures. Like here we have like this, I don't know, Christmas tree, upside down human, tough to say. So that definitely gets us in like, oh, this is like malignant for sure. And I would agree, except that there's a caveat to this lesion, which we'll get to in a bit. There's also some extravasated erythrocytes, so we could potentially consider a vascular tumor. And the most common culprits of poorly differentiated lesions on the sun-exposed head and neck of elderly individuals would be carcinoma, melanoma. So when given the pleomorphism, you could also consider a pleomorphic rhabdomyosarcoma. So that's the differential we're going to work with, and we're going to stain it up. We're going to do keratins for carcinoma, including a high molecular weight keratin. We're going to do melanocytic markers, so SOX10. Let's go with the SOX10. Vascular, let's do CD31 and ERG, and then a Desmond to rule out smooth muscle differentiation, or muscle differentiation. Desmond is specific to muscle, but it can be smooth muscle and skeletal muscle. All right, they all come back negative. Now what? All right, so we've excluded pretty much everything that looks like this could be, especially given the clinical setting. And we're left with essentially a typical to pleomorphic epithelioid cell neoplasm. The differential includes atypical fibrosanthoma and pleomorphic dermal sarcoma. Now, why can't I tell the difference? Well, in this particular case, it's because the lesion is present along the entirety of the base. So I don't know how deep it goes. The differentiation between atypical fibrosanthoma and pleomorphic dermal sarcoma can be made by discerning whether or not the tumor goes into the subcutis. If it goes into the subcutis, it is a pleomorphic dermal sarcoma. There are some other criteria to get to pleomorphic dermal sarcoma, which include lymphovascular space invasion and perineural invasion. However, extension to the subcutis is the most common reason why one would upgrade from AFX to PDS. And then the question becomes, why does this matter? Well, if the lesion is an AFX, it is cured on excision and you're pretty much done. The thinking being that if it's an AFX, it should not recur and it is just completely done with it. Never going to see it again. If it's a PDS, you're saying, hey, this lesion has a potential for local recurrence. Not only that, it has a chance of metastasizing. So it is a very important distinction to make. And in terms of at least how I sign these out, I make that very clear in the comment and say, you know, this is the differential. This is why I can't tell. You've got to excise this thing, and then we'll be able to see exactly what this thing is. Yeah. So that's, I think, it for this case. And actually, that brings us to the end of our case discussion. If anyone has any further questions or concerns, or you know, I brought something up that they want to know more about, feel free to contact me. My email is goaxaca, that's GOAXACA at sagisdx.com. Thank you so much for tuning in and have a great rest of your day. Thank you.